There's an acronym that everyone in the Medicare space is talking about, and for once, it's actually not E&M. It's not TPE. It's not even RAC. It is RAD-V. It is at the top of the LinkedIn feeds, the compliance chatter, and a lot of compliance nightmares. So today we're going to be unpacking exactly what is a RAD-V audit, why they are ramping up, and what you need to know whether you're coding, auditing, or just in healthcare and trying to keep compliant. If you're new here, hey, I'm Victoria. I'm a medical coder, auditor, educator, and content creator. And on my channel, I provide tips, tricks, and tutorials to help you be successful in a medical coding career. If you haven't already, highly encourage you to subscribe and hit the notification bell so that you can get alerts when I post new episodes. Now let's get into RADV. RADV stands for Risk Adjustment Data Validation, which is a process that CMS uses to make sure that Medicare Advantage plans, which are those Medicare replacement plans, that they only get paid for health conditions that are genuinely supported by the documentation. Things that the clinicians have documented that this patient has, and it's supported because we can see that they have a medication for it. They are managing it in some way. They are assessing it or treating it in some fashion. And what CMS does is they randomly select patients and they check their health records to make sure that those documented diagnoses, especially those that are feeding into what we call HCCs or hierarchical condition categories, that they are properly supported in those medical charts. And if they're not, those Medicare Advantage plans might wind up facing overpayment recoupments. So essentially what's happening is CMS is auditing these Medicare Advantage plans to confirm that the diagnoses match what is in the chart. If the chart doesn't back it up, then the payment's not going to hold up. But it's not every single diagnosis. They're not looking for every single ICD-10-CM code in every diagnosis. There's just select ones that are more costly to treat. And because they're more costly to treat, CMS gives these Advantage plans a bigger stipend because they know it's going to cost more for them to take care of those patients with certain conditions. Think less of your like UTIs and strep throat and more things like the patient has cancer or kidney failure or complicated diabetes or COPD, things that we know are going to be very costly to treat. So CMS says, hey, we have all of this budgeted money to take care of these patients, but now they have a replacement plan. So here, replacement plan, we anticipate that you're going to need this much extra money to take care of these patients because of this cost of care. We're expecting so many hospital visits, so many specialty provider visits. So here's the extra money that you need to take care of all of those patients that have these high risk, high inexpensive conditions. So where does the problem come in? Well, the problem comes in when diagnoses are reported via the ICD-10-CM codes and they're not supported in the documentation. Or when these Advantage plans do weird stuff, like use computer programs and different algorithms to inflate diagnoses or to maybe misrepresent the full picture of the diagnoses that the patient has. In May of 2025, CMS dropped a bombshell. Effective immediately, all eligible Medicare Advantage contracts are going to be audited every single year, which is a jump from around 60 plans to around 550 plans. Not only that, but CMS is planning to clear the audit backlog, so all the way back to 2018, and they're claiming they're going to have this done by early 2026. So they're going to be hitting it like rapid fire. Also, the number of records that they are requesting per plan is skyrocketing. So it's going up to 200 charts per audit. And because of that, they're also ramping up their staff. So they're going from around 40 coders to 2,000 coders by fall of 2025. Note that I said that they are hiring coders. They are not making AI bots do the audit because AI is not a very good auditor. All of this means that RADV audits are no longer rare. They are here, they are intense, and everyone in the Medicare world needs to be alert. The stakes are very high. Unsupported diagnoses aren't just going to be denied and repayment for that one diagnosis. They are extrapolated across the entire patient population for that plan, meaning overpayments get multiplied. So if we find 1 in 10, we're going to assume that there's 10 in 100 and so forth. CMS and MedPAC estimate the overpayments to the Medicare Advantage plans range from anywhere from 17 billion up to potentially 43 billion dollars annually. That leads to clawbacks, audits, even DOJ and False Claims Act investigations, especially when they are finding patterns of unsupported diagnoses. The RADVs, they're not like a mild audit. It's not just like a TPE where they're like, hey, we're going to take a little peek so that we can better educate you. It is like a blaring alarm system that inaccurate documentation is not an option anymore. And it also confirms what we have been saying in the coding world for years, that the diagnoses need to be accurate. So while we're still primarily in this fee for service world where it's like you do this service, you get X amount of dollars, you can't just toss out diagnoses anymore and continue to slap on unspecified codes. If the Medicare Advantage plans that you are contracting with as a provider are losing money because of your crappy documentation, you can imagine that that is going to trickle down to the provider level in one way or another. Now, on LinkedIn, especially, everyone is sounding all of the alarms. You're seeing huge reactions from people, and they are like all over it. Some people are just slapping that panic button, but other people are shifting to strategy. There is a need for more precise coding and documentation and education on that documentation to support the coding than there has never been before, especially surrounding diagnoses. Some organizations have had this down for years, but others are now going to be scrambling to build year-round documentation programs because you can't just audit prep and do this all in a couple of weeks. So here's what organizations really should be doing right now. Year-round documentation training, not just scrambling when an audit hits and going, "Oh my God, like what have we been doing for the last 3 years? I think we've been documenting these incorrectly or coding them incorrectly." I would also recommend maybe some internal RADV mock audits. In the past, especially in things like family practice, we've done E&M education. Oh, is this a 3? Is this a 4? Oh, well, I think this should be a 5. We need to look at the diagnoses. We need to catch these gaps before CMS does. And then also do the provider education to follow up on that. Clarify like what documentation is required to support these HCCs, these diagnoses that are on this review list for RADV. And I would also say update your contracts and your clawback protections. Know your rights if that plan intends to recoup what you might be facing as a provider. And you as a coder should be speaking up. This affects the compliance and the payment accuracy, and you don't want to fall prey to some of this activity. And if you want to learn more about risk adjustment and about HCCs, you can do that by studying for the CRC credential with the AAPC. I actually have a great companion course for this. So if you're looking to maybe just do like a study guide, you're like, I know ICD-10 CM basics and stuff, and you're just like, I'm going to buy the study guide, but you want something in conjunction with that to self-study. My course is not a full-blown course, but it's definitely more than just a review, and you can save 20% on the course by using code YTCRC sale at contempocoding.com. So, documentation precision is more important than ever, making sure that we're not just clicking buttons on AI bots and having them support documentation of things that may or may not have happened, and then not looking at them and having diagnoses go out and all incorrect. Everything has to be supported with clarity, and with something to back it up that it was managed, evaluated, addressed, treated, something. So get audit ready now, not later. The audits are happening. They are here. They are comprehensive. Push for training, for templates, for provider support and internal workflows that anticipate this level of scrutiny from CMS. So that's the rundown. RADV audits were always important, but now they're quite inescapable because CMS has turned them from random checks to more routine annual investigations. Let me know in the comments, what is your biggest RADV challenge? Don't forget to like, share, and subscribe. I will see you guys in the next video. And until then, just keep on coding on.